of the day. Seniors in the Kerala Federation, Paili sir, Ambuja madam, Gracie madam, stalwarts in our association, Fesi, Ashwath, all presidents and secretaries of societies who have joined, each one of you in the audience, seniors from outside of Kerala. Very good evening to all of you. I think the context under which this meeting is being held is by now very well known to each one of you in the audience. And I thank all of you on behalf of the Federation for being part of this discussion. Just a quote from JAMA 1892, Assault on Medical Men. Just a quote which has become so prophetic now. I will just read it out. No physician, however conscientious or careful, can tell what day or hour he may be the object of undeserved attack, malicious accusations, blackmail, or suit for damages unknown to him. I think that is the context, and this prophetic statement made in 1892 is coming more and more true, and it highlights the need for sessions like this to make our community aware of of the legal aspects of what the practice that we are following. We are very sincere doctors, but we also need to be aware of the legal aspects and to know that any day we may land in trouble. Another message from such episodes that are occurring now is that we should stay together as a community, and it is a time for organizations like us and Kerala Federation and organizations like this to stand up and defend our colleagues. I wish to congratulate Subhash and our President Ajit sir, Shaijas, and all who have taken this initiative, and we have taken it upon us in the Kerala Federation to defend our member and to protect her in every way possible. So with these few words and words of welcome on behalf of KFAG, I think Ajit sir has not been able to join. As soon as he joins, I think he'll be speaking a few words also. I welcome all of you, and I hand over to Subhash to conduct this session. I have one request, like how Subhash mentioned, please put your questions in the chat box and let us not wade into controversial areas. Let us stay free of controversy, yet let it be a learning message with a lot of take-home messages. Also, I will request Subhash that at the end of it, if the recording is made available, we will put it up in our YouTube channel like the previous session that we have done, so that it will be always accessible to all people, except for maybe the discussion part in the end. Thank you, and over to you, Subhash.
Yeah, thank you very much, sir. As you rightly said, sir, the discussion part we will take it in the end, and then regarding the portion of whether we would like to put it in YouTube, we'll put it out later, sir. Again, I would add at the outset, let me thank our president, our association president, Dr. Ajit sir, Secretary Venugopal sir, senior members of faculty, Dr. Paili sir, Dr. Shekaran sir, Dr. Rajshekaran sir, Dr. Ashwath Kumar sir, Dr. Fesi Louis sir, senior member Dr. Gracie Thomas madam, and all the seniors. Like we have the past president, Dr. Chellamma, Dr. Prasanna Kumari madam, and a lot of other seniors over here. I welcome all of you for this wonderful session, and also for all the delegates who have joined over all the country. Right, without wasting much of a time, I would go straight away into the topic of today. As you all know, in the background, what we have done is the intrauterine fetal death, the stillbirths, and the controversies. I think let's go. We'll take everything, all the three factors, and then go ahead and see what. Because ultimately, at the end of the day, it all ends up in the same way. Where when it comes into medical legal, it's the same. So we have luminous among us, Dr. MC Patel sir, who has readily considered. Yesterday afternoon, my SOS to sir, and by evening, sir said yes, no problem, we'll go ahead, because I thought this is the apt time for. And I'm very grateful that Dr. Gracie Thomas madam, who had initiated a lot of discussion the last 24 hours with Dr. Fesi Louis sir and Dr. Ajit, is also over here along with Dr. Venu. Thank you, sir. Thank you, madam, for joining us today. Now, again, we all know Dr. MC Patel sir is the former vice president of the Federation of Obstetrics and Gynec Society of India, and also the Medicolegal chairperson previously. So, sir would like to talk on intrauterine fetal death. I would invite the chairperson for the day today evening, Dr. Advocate Shyam Padman sir, who would be the chair in this session along with Paili sir. So Dr. Paili, as we all know, is our own senior, very, very senior and a respected faculty and our medical expert. Dr. Shyam Padman is the standing counsel, as I said, he is the standing counsel for the IMA of the Kerala, not only the Kerala state, he is for the Kerala state and the High Courts and the Supreme Court. And sir would give us the legal part. So we have taken care of both the ends, so that we have the hawk and the dove both over here. And so we'll have the middle part today. So that's what I meant. Rajesh, can you please help me out with the CV for the official? Fesi sir, yeah, you were speaking something. Fesi sir, yeah, okay, yeah. It's for the official Shyam Padman sir's. Yeah, MC Patel sir, as we all know, is a consultant at Ahmedabad, and he's the vice president of Fox in 2018, and he's been the organizing secretary of AICG 2017 and the chairperson of ethics and Medicolegal committee. And he's a host of other things, and he's helped a lot of us, a lot of gynecologists, for in our troubles. Right. But Advocate Shyam Padman sir is a BA and LLB and LLM from Calicut, and he is also a postgraduate degree in medical law and ethics from the National Law School at Bangalore. And it's a very tough course. Since I've also done the same, I know this is a very tough course. Of course, for them it's very easy. And sir practices in High Court of Cochin and also at the other places also. He's been practicing for 30 years, as we all know, and his specialty is medical jurisprudence, consumer protection, and cyber law. So except for the cyber law, medical jurisprudence and consumer protection is something which comes under our, where we always have a lot of problems with. The doctors have a lot of problems. Thank you very much, sir, for obliging to our request, sir, and joining for this. Right. Now I would hand over the session to chairpersons Paili sir and Shyam Padman sir. Rajesh, thank you very much.
Subhash, thank you very much. It's a very appropriate thing to do because everybody is very upset about the verdict that has come recently. And I know that that is the background for the discussions today. And again, only when such things are focused, it will hit us. So let us wait and hear the opinions of the various experienced people, both from the side of law as well as from the side of medicine. And probably after that, discuss what will be the appropriate thing to do. Thank you for the opportunity.
Thank you, Paili sir, and thank you, Subhash, for this opportunity. Even though it was a late night call yesterday, but still, I'd say like doctors, we are also now asked to be prepared in the 11th hour. Always ready to do whatever is necessary. Wonderful. Now that we have Patel sir among us, I think we'll just ask for his opinion or observation regarding the current scenario, a 5 minutes, so that we can just proceed with the deliberations, and we'll have our constructive inputs later as we go on.
So thank you, and please allow me to share my screen. Is it seen, Subhas?
Yes.
Yes, sir.
Okay.
Yes, sir.
Okay. So we will be discussing intrauterine fetal death, care in the aftermath and beyond.
Patel sir, just 1 minute, sir.
Yes.
Rajesh, can we mute everybody, Rajesh? Can we mute everybody? Rajesh, can we mute? Patel sir, please carry on. Patel sir, please carry on. Please carry on, Patel sir.
So you'll have to unmute. Yeah.
Yes.
Please.
So today we will be discussing this intrauterine fetal death, care in the aftermath and beyond. I will touch medical part, legal part, and medico-legal part as a whole, and then it will be open for discussion for all of us. So, warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank Iufd and President Dr. Professor Ajit, good friend of mine, and Dr. Venu, and of course Dr. Subhash. Subhash just called me yesterday evening or rather night, and he taught me all this detail, and I straightway said, yes, it is a need of time, and this matter should be discussed as early as possible, and we should come out with this some concrete ideas on part of our association. At the outset, I would like to thank Dr. Jyotika Desai for sharing me few of the slides as far as my presentation of Iufd is concerned. I always start my talk like this: is it worth discussing? And it is always yes. And if it is yes, then why? Because in our day-to-day obstetric practice, we are dealing with so many cases like this. And when they are high-risk pregnancy, then it is all likely that accident may happen at any time like this. and our situation becomes very tricky. And medical litigations are increasing in number constantly and steadily. And unluckily, we gynecologists, friend, rank first as far as any medical legal consequences are concerned. And our situation is like this. We have to save mother, we have to save baby, and at the same time, we have to save our own cap, and that is obstetric. So we have to deal with situation accordingly in best possible manner. Our situation is like just this innocent bird, always at danger of cobra of law. So this is real scenario in our day-to-day obstetric practice. So let us say a case of Iufd, and these are the cases which are potential cases as far as litigations are concerned. Let us start with few real case happened in some of the cities of our country. It was case regular antenatal checkup, sonography every time, told everything to be normal except polyhydramnios. At 34 weeks, it was found intrauterine fetal death on routine antenatal checkup. Cesarean section was advised, preoperative investigation before cesarean section, and blood sugar came out to be 432, which was never advised prior. Case was filed, notice was served, yet this case is to be decided, it is under matter, but compensation demanded is 1 crore. Let us see one more case. It was unbooked patient. This is also a real case happened in state of Gujarat, and luckily I was counsel for both of the gynecologists. It was primary 34 weeks pregnancy with PIH, and this was very first visit of this particular patient to this gynecologist, because previously patient was at her in-laws house and now she was at her maternal place due to customary tradition in Gujarat to have first delivery at maternal place. So she was advised necessary investigations and treatment for the same on very first visit. But unlucky on part of patient as well as that particular gynecologist, very next day she developed abruptio placentae and intrauterine fetal death. Cesarean section was advised, but relative opted option to go for second opinion in nearby town. It was small town of Gujarat, and went to surgeon in nearby town. Cesarean section was done. Again unlucky on part of patient, and that surgeon also, she developed atonic PPH and hysterectomy was done. Imagine the situation, primary patient, intrauterine fetal death and hysterectomy, and notice was served. And allegation to first gynecologist was not properly managed to prevent abruptio placentae, which led to intrauterine fetal death. And to surgeon, allegation was not tried to prevent PPH, and atonic PPH was not managed properly. So in this type of situation, many a times we face this type of situation. But how, doctor, you said everything was all right just 10 days back, and how it happened? So this is day-to-day scenario in our practice as obstetricians in our day-to-day practice. And it has great physical, emotional, psychological, social trauma for parents and family when it is declared intrauterine fetal death. We all know, but we have some limitations. Then let us see at what gestational age would you label intrauterine fetal death. So death of product of human conception before the complete expulsion or extraction from mother, irrespective of duration of pregnancy, that is not an induced termination of pregnancy, is stamped as a intrauterine fetal death. But as far as stillbirth is concerned, is typically defined as fetal death at or after 20 to 28 weeks of gestation. So it simply means after age of viability. As per WHO, if it is more than 22 weeks and weight of fetus is more than 500 grams, and as per UK guideline, it is more than 20 weeks considered as a stillbirth. As far as incidents are concerned, it is 1 into 2,000 babies, and as far as statistic of USA is concerned, 5.2 in 1,000 live birth it is noticed, and almost same since last 20 years, and might be due to increased obesity and age. It was the observation on part of USA. If we go with a global scenario, I do not want to go into detail, but India contributes 22.6% of world's stillbirth conditions. And as far as worldwide stillbirth rate has been falling, so previously in 1980, it was 35 per 1,000 live birth, and it is declining 2015 to 15. And there is variation in rates also. If we consider low socio-economical group, then it is 21 per 1,000 live birth, and with high socio-demographic index country, it is 3 per 1,000 live birth. And it is very obvious, giving birth to death when you expected life. So in India, roughly 22.6, that is 23 per 1,000 live birth is the figure. As far as path ahead is concerned, in a case of IUFD or stillbirth, care beyond. So first, confirm the diagnosis. And there are so many ways, but let us see. There are certain things as far as confirmation of diagnosis is concerned. 50% of stillbirths are preceded by decreased fetal movements. Sometimes fetal movement perceived even after intrauterine fetal death. Fetal movements can correlation as false positive rate up to 30%, and auscultation may be inaccurate. So with inaudible fetal heart sound, baby may be viable. So these are the observations from certain groups. So confirm the diagnosis, and gold standard is ultrasound. So as far as placenta is concerned, you can have a location and retroplacental bleed or clot. And as far as fetal part is concerned, you can confirm presentation, approximate weight of baby, if at all present, then Spalding sign, eye drops, and gross anomaly. So ultrasound is the gold standard as far as confirmation of diagnosis is concerned. And we have to go for clinical evaluation and exclude immediate severe maternal morbidity also. So if at all it is associated with maternal morbidity, then our action should be very prompt to deal with the condition accordingly. So exclude immediate severe maternal morbidity like acute abdominal pain, rule out abruptio, vaginal bleeding, labor symptoms, PPROM, obstetric emergencies like eclampsia and maternal collapse. So if at all we are dealing with this situation, then we have to deal very promptly. Evaluation of probable cause of IUFD. If we have time and morbidity is not the prime concern to go with the delivery, then we should evaluate probable cause of IUFD. It could be antepartum, it could be intrapartum, related to placenta or cord. And this is very common statistic. As far as fetal part is concerned, almost 25 to 40%, placental part 25 to 35%, maternal part 5 to 10%, and unexplained 15 to 35%. As far as fetal part is concerned, these are the certain conditions in which it may lead to IUFD, multiple gestation, IUGR, congenital abnormality, genetic abnormality, or infection. As far as placental part is concerned, cord accident, true node, cord around neck, cord prolapse, abruption, premature rupture of membrane, and vaja previa. And as far as maternal part is concerned, extremities of maternal age, maternal obesity, prolonged pregnancy more than 42 weeks. Here it is specifically mentioned more than 42 weeks. Diabetes mellitus, poorly controlled, SLE, infection, hypertension, preeclampsia or eclampsia, hemoglobinopathy, RH diseases, uterine rupture, antiphospholipid syndrome, acute severe maternal hypotension, and maternal death. But at the same time, it is also to be kept in mind, in 15 to 35%, it is still unexplained, and we are facing situation of Iufd. So evaluate probable causes of Iufd, and this is very important thing. As far as IUGR part is concerned, 3 to 7 times higher in this type of situation. As far as placental dysfunction is concerned, even without FGR, it may lead to IUFD. As far as abruption is concerned, 1% in pregnancy, and as far as abruption is concerned, 10 to 20% of stillbirths are recorded. In infection, if it is lower middle economic group, 50%, and in high income group, 10 to 25%, and genetic and congenital anomaly, and just I mentioned unexplained part. Also, once it is established that it is IUFD, we have evaluated probable cause, then now questions come: communication to the patient, communication to the next of kin, and relevant authority as per guideline in institution to inform higher authority or HOD or superintendent of the hospital as per the protocol maybe. So breaking bad news, the most terrible thing that can happen to any obstetrician to declare bad news in his career. And where do we go from here? Because it is very sensitive time, very sensitive issue when we have to declare bad news. So this is standard guideline, that is SPIKE. As such, it was used in oncology department, and a 6-step protocol for delivering bad news and application to the patient with cancer, and it was found by Walter F. Bale et al. So as far as any bad news to be declared, then these are certain criteria we should keep in mind, and we will discuss one after another as far as setting, patient's perception, patient's invitation, knowledge about the condition, empathy and understanding emotions, and strategy and summary of the condition. So it is very important as far as the role of rust team is concerned. Of course, you can declare bad news by your own also, but if there is rust team in your society, it is always better to call of our colleague, and in presence of rust team, you should declare any bad news, and never hesitate to go for help. If any of your professional colleague has called for help, never hesitate to go for help, and you are under obligation to reach our friend in any given situation to help him or her. And as far as communication with relatives are concerned, simply हम आपके बच्चे को बचा नहीं सके, it looks good in Hindi film, but in our day-to-day practice, it is not so simple to say just like thing. Inform condition from time to time. If you are dealing with a high-risk pregnancy, or if you are dealing with a certain condition in which IUFD is known, or if you are dealing with a condition of fetal distress or maternal distress, inform patient and relative time by time about the condition, so that they could be mentally prepared at the time of event. And it should be declared by senior most person of the team and not by junior. Simply your resident doctor or junior person should not declare this type of news, and it is duty of senior most person of the team to declare this type of news. Of course, if you are alone running a nursing home, it's a different scenario. But when you have treated patient in group, then senior person should take the lead. Face together with the RUS team if available, just I mentioned. Be polite and sympathetic, but assertive at the time of declaring the news. Be prepared for a knee-jerk hostile reaction, because in few of the condition it is also likely. Be prepared for mob frenzy. In few of the condition it is also possibility. Do not lose patience. Whatever happens has happened, but you have to be very quiet in this condition at the time of declaring the news. Do not blame each other. When more than one person is involved in the treating the patient, do not blame each other as far as declaring the bad news and after discussion is concerned. Use private room. This is not news to be declared in ward or in lobby with any relative or so. So use a private room. Arrange interpreter if necessary, because many a times it is all likely that patient may not understand your language. So you can have an interpreter also, but avoid using family members as an interpreter, because you never know whichever you have explained, whether it is properly communicated to the patient and relative or not. Discuss care and decision with both parents and or a support person and document plan of care. So further planning of treating patient is also to be discussed with patient and relative. Nurse, registrar, other members of multidisciplinary team should be available to give parents further information on diagnosis and outcome. So if patient or relative demands to discuss anything related to these persons, then they should also be available. But word of caution, before that, you should have a talk to nurse, registrar, and all your members of team to have a uniform dialogue, because whatever has happened and how you dealt with the condition, how you treated the condition, it should be uniform as the time of declaring or conversation by anybody or any member of your team. So when to break bad news? So if it is an OPD patient, if patient has come in OPD in routine OPD hours and it is found on routine antenatal checkup that it is Iufd, then without much delay, but ensuring confidentiality, you can declare in your consulting room with patient and relative whosoever is with patient. If patient is indoor patient and acute maternal worsening, then clearly inform fetal demise while stabilizing mother rather than leave it for later. If it is critical care setup, then priority is maternal well-being and disclose at the earliest when condition is stabilized and inform next of kin about Iufd. No need to inform mother in this type of critical care situation. As far as intrapartum part is concerned, it is based upon the stage of labor. If imminent delivery is expected, then you can declare it with relative but not with patient and focus on hastening it, but pre-warn patient there are consent. So when to break up this bad news is an art, and do not delay if condition permits. Now it comes a management plan as far as delivery and certain investigations are concerned. So as far as management plan is concerned, clearly document in a chart in consultation with parents. Whatever plan you are going to plan and offer to the patient and relative, it should be well documented. Include their wishes with regard to meeting members of multidisciplinary team. Management may be expectant or involve medical induction of labor as per the condition of patient allowed. Urgent delivery is needed in case of abruption, APH, preeclampsia, eclampsia, sepsis, prom. Otherwise, you can go for expectant treatment also. But as far as expectant treatment is concerned, more than 90% women go into labor within 3 weeks of IUFD. But disadvantages with this expectant treatment is 10% of DIC in 4 weeks and 30% after 4 weeks. So if you are going to go for expectant treatment, then you are under obligation to explain everything related to possibility of DIC with the patient and relative. May have difficulty in identifying the sex if it is delayed, because many a times the delivery of macerated child is the situation. And value of post-mortem examination decreases if we go with expectant treatment in established case of Iufd. Delay for more than 48 hours do not add any risk if no other associated complications like sepsis, preeclampsia, placental abruption, membrane rupture. Of course, in this type of condition, we are not going to go to waiting, and we will be dealing situation promptly. If delayed more than 48 hours, then arrange twice weekly full blood count and coagulation profile. And as far as further management plan is concerned, as far as induction is concerned, offer the choice of induction if indications for induction are present and commence induction. If alternative mode of delivery, then document the reasons. If induction is not possible, and if you have to straightway go for cesarean section or so, then you have to document the reason why it is urgently indicated. So as far as labor room is concerned, and before that, a private room should be given to the patient who is a patient of Iufd. Display hospital pregnancy loss symbol on door of room. It is in many of the hospitals, it is a tradition that this type of symbol is put on the room of patient, so nobody disturb a patient in other way. Allocate one nurse to the family for intrapartum care, and prepare parents for appearance of baby after birth. It is very important thing. If relatives are keen to see baby, we are under obligation to make arrangement for that. But discuss about parents seeing and holding the baby after birth. Check that full blood count, group and coagulation screen have been done in last 24 hours. It is request on part of anesthetics. So use the partogram during labor, because it shows your consent to take utmost care in any given situation, and it could be good defense in your favor if at all you are facing any kind of litigation. Get verbal consent for initial examination when stillborn baby is delivered, and when you are going to examine that baby, then you have to take verbal consent for initial examination. Offer parents opportunity to dress and hold the baby, because in many of the family it is custom, even if with dead baby, they nicely dress the baby, hold the baby, they have photographs also. So allow them, so honor their sentiments, do not resist for anything. Assist parents in taking photographs of the baby. If patient is RH negative, then send cord blood for further management. General appearance of placenta, weight of placenta, cord and membranes, any retroplacental clot, we have to examine everything for further management accordingly, and it should be well documented. Number of vessels, any true node or any cord around neck, tight or loose, should also be mentioned in our case paper, because it becomes defense in our favor if at all we have to face any litigation. Sample of placenta and or cord for cytogenic testing as per local protocol before placing in formally. If it is a local protocol of your institution, then you can proceed accordingly. But of course, for that, consent of patient and relatives should be taken. Placental swab obtained from fetal and maternal surface and to be sent to rule out certain conditions. Placenta sent for histology with appropriate request form. If it is tradition in your institution or academically, if you want to study further, then with consent, you can send placenta for histological examination. And any other comments if you have, you can do it. But this is also very much important thing. Take or offer mementos. Just I mentioned, in so many of family, they are interested to have a hand or footprints, lock of hair, name band, cord clamp, memory box, photographs, whole body X-ray, infantogram, or ultrasound scan. So please allow them. So please honor their sentiment. As far as fetal autopsy is concerned, if you are interested to search certain things, but in this decision of parents is very much important, and they should give a free and fair consent for fetal autopsy, a very personal decision on part of parents. It helps diagnose the cause of death or add information in 20 to 76% of the cases. So we should explain it to the parents, but may change final diagnosis or affect genetic counseling also. So we should keep that in mind, and we should explain this also to the patient and relative. In clinically unexplained stillbirth and relevant condition at death, classification is recommended, and we should follow that also. This is also very much important. Offer full if parents decline autopsy, then offer full examination by neonatologist, pediatrician, pathologist, but of course, consent for the same also to be taken for external examination and for clinical photographs also. So prior consent is very much needed. And do not forget, the bereaved parents need a lots of support. Each person is different and will go through their own grief as it suits their personality. You can't do anything to make it better, but you can be present all the time with patient and relative to support their sentiments. As far as documentation is concerned, you have managed the case very nicely, but ultimately documentation and record keeping is always at your rescue. So whatever steps you have taken to deal with situation accordingly, it should be well documented. And as far as documentation is concerned, OPD case paper, indoor, whether patient was book patient, whether patient was unbooked, whether it was emergency patient. So you have to document everything. And this is a list as per certain institution, but you should have a detail of the documentation as far as this type of cases are concerned. Follow local protocols, because in many of the hospital, it will be a protocol and it should be entered in labor ward register, stillbirth register, stillbirth certificate, notification. This is very important. When we notify live birth with appropriate authority, at the same time, stillbirth is also to be notified. There are prescribed forms, that is form 1, form 2, form 3. Form 1 is for live birth, form 2 is for death, and form 3 is for stillbirth. And with that form, we have to notify the condition to appropriate authority within stipulated time, and ensure discharge summary provided is very accurate. When you discharge patient, discharge summary should be very much up to date and with all the details about medicine to be taken, about diet, about exercise, about follow-up visits, about rest. So everything should be well mentioned in discharge summary. As far as preventing future recurrences, it is also very important path ahead as far as this type of cases are concerned. So preventing recurrences, as far as this statistic is concerned, 592,000 stillbirths per year in India, and 50% are intrapartum, 43% are growth retarded. Can't we prevent this? So it is our duty to go for this type of situation, not to reoccur again in the same family. So as far as future pregnancy is concerned, strengthen antenatal clinical screening, risk stratification. Antenatal pickup is key to management, clear referral algorithm, protocol-based management, skill training and equipment for management, moral support to the couple, and patient delay in admit. There are certain conditions where we enter into this type of situation of IUFD. Patients delay in admission, delay in care on admission to birth facility, delayed operative delivery, unavailability of health workers, inadequate intrapartum monitoring, misuse of oxytocin, and neonatal resuscitation failure. So these are the certain conditions we have to take into consideration not to end up into this type of situation. And ultimate goal is every newborn action plan target of national stillbirth rate of 12 or fewer stillbirth per 1,000 birth by 2030, and this goal is given by central government. So you were born silent, perfect and beautiful, still loved, still missed, still remember, every day still born, but still born. And where are the areas for litigation? Now coming to legal part or medical legal part, just I completed medical part. So which are the areas for litigation as far as IUFD cases are concerned? In this type of cases, whenever we are facing litigation in court, this is the prime question which is asked: was it preventable? And in so many conditions, you cannot say no. So if it is yes, then second questions come: what did you do to prevent it? And why you couldn't prevent it is the main question many a times asked in the court of law by opposition. And did you diagnose in time? So this is one more question, and very important question is, did you manage way in which any prudent doctor would have managed? So if you have managed case in a given situation, way in which any prudent gynecologist would have managed, and if you can prove this, then you could be out of problem if at all you are facing any litigation. So these are certain areas: failure in diagnosis, delayed in diagnosis, improper management, and recurrence. So these are the areas where we are in a position to face this type of litigation. So many times, as far as recurrence is concerned, or to avoid IUFD is concerned, this is a common allegation: no proper care taken to avoid IUFD, or in history with IUFD and recurrence, then no proper care taken to avoid recurrence. So what to do and how to prevent this? Every IUFD case is potential threat as far as medico-legal consequences are concerned. So look like avoiding medico-legal problems in our practice is a difficult balancing act? No, not at all. So what to do and how to prevent? So practice foreseeability and anticipation, good communication and proper consent and proper documentation, and you will be simply sailed through. So as far as foreseeability is concerned, anticipation is concerned, if you are dealing with a high risk pregnancy, naturally you should anticipate possibility of IUFD, say for example GDM, hypertensive disorders in pregnancy, because we know sudden IUFD is known in this type of condition: postnatal, severe anemia, severe IUGR, and you should be readily available to offer intensive care as far as any given situation is concerned. But at the same time, proper counseling is very much needed, and it is very obvious. More is the time you spend with patient in consulting room, less is the possibility you needing to spend time with that patient in courtroom. And communication is key to avoid litigation. And it is very obvious. We might have the best medicine in world, but it won't be successful if patient doesn't understand it. And when we are in OPD or at the time of admission, usually our conversation start: what is the complaint? And there are so many questions on part of patient: why did it happen? why it happened again, will it happen again, how it can be avoided, could it have been avoided. So there are so many questions on part of patient as well as relative, but we are under obligation to explain everything related to alternative modalities of treatment, morbidity, possibility of probable expense, possibility of mortality, probable prognosis, complications, possibility of blood transfusion, risk involved. And as far as these alternative modalities of treatment, I will discuss just a little later on with very important case decided in Supreme Court. So this is very important thing as the time of counseling. So if possibility of preterm delivery, then we have to counsel for steroid, for outcome of the baby, and we have to give clear idea about possibility or requirement of NICU care also. So if you have counseled patient well, then it will be easier in court of law to defend. And it should be in a very simple language and no much medical jargon. We should explain everything to the patient in a language in which patient can understand very easily. And no rosy picture or no tall claim about result. Because in our obstetric practice, we consider our result like Aishwarya Rai, but it may turn like this at any time. So no tall claim, no rosy picture, because in eye of law, when you claim to be master, then you are supposed to be master. So communication with patient and relative is very much important. And when you take signature on that consent paper, it becomes a documentation of your communication. And in this particular case of C. Jaipal Reddy versus Dr. Padmini Velluri, in National Commission, it was very specifically mentioned that consent paper is not mere piece of paper where you have to take signature of patient and relative, but it is a documentation. It is a document of your conversation with the patient, your communication with the patient and relative about your treatment plan further, and it is a good documentation of your communication. So as far as consent is concerned, you should enter everything in consent paper about your treatment plan and condition of the patient. So it is a documentation of your communication. And when you offer all your records in court, it becomes a communication of your documentation in court of law. So naturally, records are always at your rescue, and antenatal monitoring and labor monitoring, it should be well documented, because you can prove in court of law that you have left no stone unturned to take utmost care of patient in given situation, way in which any prudent obstetrician would have taken. So keep your records up to date. What was done, nothing was neglected, and given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. A doctor is bound to produce record whenever asked by the court, and if he doesn't, then adverse inference might be drawn. And it is very obvious. I say in my all lectures, good records are always good defense, poor record is poor defense, and no record is no defense. And it has been my experience during my medical legal practice. We doctors' friends are very poor as far as record keeping is concerned. And as far as era of this COVID-19 is concerned, at the time of documentation and counseling and taking consent, we have to explain to the patient possibility of spread from patient to others, from others to patient, all the precautionary measures. We have to inquire about the traveling history, international, national, and any history of contact with COVID patient or suspected patient, any history of quarantine, whether home or hospital. And if you are dealing with a suspected case, then you have to subject patient for RT-PCR. And if it is positive, if your hospital is designated, then you can very well treat the patient, or you have to refer patient to designated center. But at the same time, you are under obligation to inform appropriate authority as per government notification. But now I am coming to the certain very important landmark judgment which has come up with apex court. And the main landmark judgment, this is Jacob Matthews versus State of Punjab, which was decided in 2005 in one of the cases. So in that particular case, it was very clearly mentioned by Justice R.C. Lahoti and his team, a case of occupational negligence is different from one of professional negligence. A simple lack of care, an error of judgment, or an accident is not proof of negligence. So long as a doctor follows a practical accepted to the medical profession of that day, he cannot be held liable for negligence merely because a better alternative course or method of treatment was also available, or simply because a more skilled doctor would not have chosen to follow or resort to that practice or procedure which the accused followed. It simply means if you have an option of modalities of treatment more than one, then you are at full liberty to choose any one option to deal with the situation accordingly. And merely on the ground you didn't opt another option cannot be the ground for litigations against you, because you are at liberty to choose any options available in best in good faith of patient. And it was discussed and very specifically mentioned in this particular case by apex court. Further, in this particular case, it was mentioned that a professional may be held liable for negligence on one of the following. There are certain conditions where medical persons can be held negligence. One, either he was not possessed of requisite skill which he professed to have possessed, or he didn't exercise with reasonable competence in given case the skill which he did possess. The standard to be applied for judging whether the person charged has been negligent or not would be that of an ordinary competent person exercising ordinary skill in that profession. So it was very clearly mentioned. It is expected from any service provider ordinary skill, not extraordinary skill. Ordinary skill is expected by law in any given situation. It is not possible for every professional to possess a highest level of expertise or skill in that branch which he practices. So it is accepted in apex court. It is not possible each and every doctor to have a highest level of expertise or skill, but if one have an ordinary skill, it is suffice. One more thing taken into consideration in this particular case, a highly skilled professional may be possessed of better quality, but that cannot be made the basis or yardstick for judging the performance of professional proceeded against or indictment of negligence. So if any ordinary skilled person has taken reasonable care as per standard medical protocols, then he cannot be held negligent in any given situation, was the crux of this particular judgment, and it is very landmark judgment and very important for us in our day-to-day practice. Furthermore, in this particular judgment, it was also mentioned the jurisprudential concept of negligence differs in civil and criminal law. As far as civil law is concerned and as far as criminal law is concerned, to hold person negligent criminally or in civil, it is a totally different, and jurisprudential concept is very clear. What may be negligence in civil law may not be necessarily negligence in criminal law. So as far as criminal liability or criminal negligence is concerned, case is to be dealt in a separate manner. For negligence to amount to an offense, element of mens rea must be shown to exist. So mens rea means guilty mind. So if service provider has a guilty mind, then only it is considered negligence criminally. And I think no doctor has any mens rea at the time of treating any patient in any given situation. So this is very important thing, that to decide any case against any doctor, criminal liability, mens rea should be taken into consideration. For an act to amount criminal negligence, the degree of negligence should be much higher, and it was mentioned gross or very high degree. So negligence should be of gross or very high degree, or standard of gross recklessness. It should be there. Then only one can be held liable criminally. Negligence which is neither gross nor of higher degree may provide a ground for action in civil law. One can go for civil suit. One can go in consumer protection for compensation. But one cannot be held liable criminally if all these parameters are taken into consideration. And one more thing, the
Mr.
word
Patel, sir?
gross. Sir.
Dr. Shyam Padman would like to join, it seems, sir.
Okay, no problem.
Yeah.
I will.
No, I mean,
finish
it
this
is more
and
like
then-
he's saying
then
more
it will
about
be open for
gynecology
discussion.
than they're saying about legal matters. No, sir, you can
No,
just
no,
conclude. No,
it will be open for discussion, but let me complete. Only few slides are there. So it will be very nice to keep it open for discussion. The word gross has not been used in section 304A of Indian Penal Code, yet it is settled that a criminal law negligence or recklessness to be so held must be of such a high degree as to be gross. So expression rash or negligent act as occurring in section 304A of IPC has to be raised as qualified the word grossly. So it should be gross, and gross negligence can only be taken into consideration. This was one more important case happened with our own gynecologist with Ghaziabad. Of course, it was case of amniotic fluid embolism. But in this particular case also, it was case of cesarean section. Point in issue was whether there was any negligence and any deficiency in service while managing the patient. So in any given situation, same question is asked, whether there was any negligence or deficiency in the services managing the patient accordingly. And in this particular case, so there were three conditions which were discussed. In order to succeed a claim in medical negligence, there are three requirements. One, the accident nature of misconduct on part of the doctor. Second, existence of proven damage. And third, its direct relationship. Doctor shall put in place all necessary measures as to the current scientific knowledge. And in this particular, they noted, we note opponent one, that is our doctor friend, perform her duty with reasonable standards and as per accepted practice, and patient was appropriately referred to higher center. This was decided in case of amniotic fluid embolism in that particular case. One more very important case which was decided in apex court, that is Achyut Rai Kobra case, and in that particular case also apex court where have very specifically mentioned the skill of medical practitioner differs from doctor to doctor. The very nature of profession is such that there may be more than one course of treatment which may be advisable for treating a patient, and courts would be indeed be slow in attributing negligence on part of a doctor if he has performed his duty to the best of his ability and with due care and caution. And in the same case, it was further added, medical opinion may differ with regard to the course of action to be taken by a doctor treating a patient, but as long as doctor acts in a manner which is acceptable to the medical profession, and the court finds that he has attended on the patient with due care, skill and diligence, and if the patient still doesn't survive or suffers a permanent ailment, it would be difficult to hold doctor to be guilty or negligence. So it simply means if you have taken utmost care as per standard norms of medical practice on that particular time, you are out of problem. And in this, one more case decided in apex court were very clear to mention Consumer Protection Act should not be a halter round the neck of doctor to make them fearful and apprehensive of taking professional decision at crucial moments. to explore possibility of reviving patients having between life and death. And doctors in complicated cases have to take chance even if the rate of survival is low, and doctor faced with an emergency ordinarily tries his level best to redeem the patient out of his suffering. So these are some landmark judgments, and these are very important cases for us. So there is always a way, and messages are very clear. Always confirm IUFD by USG. Breaking the news of IUFD should be done very carefully and compensately. It can help us avoid a lot of medical legal issues that can develop with the cases. Investigations are done primarily to find out the death. In spite of all, test cause is not found in 25 to 60% of the cases. History taking is most important part of evaluating the case of IUFD. Vaginal delivery preferred route unless it is contraindicated. Use prostaglandin with caution in scarred uterus with IUFD. Cytogenic evaluation will be helpful where no apparent cause is found. A post-mortem may be advised in certain cases, and fetal autopsy can provide an insight to the cause. Be very vigilant in next pregnancy. Continuous support and reassurance in required in next pregnancy. In any case, never take pregnancy beyond 39 weeks in a woman with history of previous IUFD. Pregnancy and labor room profile and protocols and checklists, proper counseling and consent, proper documentation, multi-speciality approach, no compromise on statutory requirements, professional indemnity, of course, it is needed in nowadays, and be vigilant in your practice and remain alert every time. Otherwise, be ready to face this type of situation in our practice and comply with provisions of law, formation of local level medical legal cell. So one can avail services from member in any given situation. Take medical legal advice from point one if at all it is needed, and have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. In 40% litigations, doctor is behind doctor, and it is a statistic given by Supreme Court, because in our fraternity scenario is like this. And so do not criticize other doctors or paramedical persons. If this is possible, this should not be the scenario. अच्छा है कि नाव में छेद हमारी तरफ नहीं है, but we never know we are sailing in the same boat. And do not quarrel between each other so that third party should be at advantage. So be vigilant in this type of situation. If cat and dog can share milk from the same dish, then why can't we? So of course fight with each other, no problem, but be ready to fight for each other. And this is very small clipping. In our practice scenario is like this. Let us see, only 1 minute and I will conclude. So, but can we do like this? If yes, then many of the problems are preventable. So, योग करे या ना करे, किंतु एक दूसरों का सहयोग जरूर करें. सत्य परेशान हो सकता है, लेकिन पराजित नहीं. And in spite of all these professional and occupational hazards, our journey to serve human and mankind is always on and on. So God bless you and have a litigation-free medical practice. And if you want to sleep like this, take tender care of your patient. Pray your Almighty God before going to sleep, and keep my visiting card below your pillow. And this is my last slide. And thank you very much, Subhas, for it is open for discussion and for comments from anybody.
Yeah, thank you very much, sir. At the outset, I would like to invite Shyam Padman, sir. It was more of a medical talk, sir. I think right now we'll come to the legal part. Sorry for the slight delay in this thing, sir.
No, absolutely okay. I recognize the presence of Honorable Mr. Justice Ramakrishnan, sir. Thank you, sir, for coming on my invitation. Thank you, sir.
Thank
I mean, it was like learning swimming through correspondence course. Like, I mean, it is indeed wonderful to hear medical men speak law and legal men speak medicine. So I thought I'll just, now that things have been, what do you call, placed in perspective by Dr. M.C. Patel, I would, I mean, with the permission of this August Assembly, let us discuss the elephant in the room.
Yes, yes.
We have been
Sir, may I
on a
just
tour of the academic.
Shyam sir, just 10 seconds, sir. May I just invite Dr. Advocate Dr. Hitesh Bhatt also here? Dr.
Yes,
Hitesh
yes,
Bhatt,
welcome, welcome. Hitesh,
Yeah.
Manish, whoever are present, they are most welcome.
can you please, and yeah, sir. Shyam sir,
So,
apologies for that. Apologies for that.
Shyam sir,
I'll just take 5 minutes and I disappear.
only 1 minute, Shyam.
Yeah.
Dr. Hitesh Bhatt is our professional colleague and he is also a graduate in law and now he is practicing law only and
Very
he is a member of Bar Council. And for your information, I am also postgraduate in law. I am LLM.
Very good, sir. Very
in,
good. Very good.
Criminal part.
I cannot make any claim of being.
Dr. Manish Machave, our chairperson, Ethics and Medicolegal Committee of FOXI, he is also law graduate, and we all friends, Hitesh, myself, Dr. Gitendra, he is also law graduate from Ahmedabad only, medical legal expert, and Manish. We are always at assistance of our FOXian friends. They are free to contact all of us at any given time. Yes, open to you, Shyam sir.
Thank you very much, sir. I just, I thought like I'll just take 5 minutes of your time because I have been given a case study or rather a case yesterday by Dr. Subhash, and I was under the impression that we'll be trying to, discuss on that a bit. But thank you, sir, for putting things in perspective because I need not enlighten this audience regarding what are the nuances of medical legal mandates, etc.
Excuse me, sir. 1 minute. If you're discussing about that case, I request all, if any are recording the.
No, absolutely no issues. Don't be so apprehensive.
Okay.
Any judgment you can critically decide, discuss, etc. That itself shows our abysmal ignorance of legal system. There is nothing wrong in that. Only thing is that you should not criticize the judge or you should not make any comments on that.
Once it is out,
there is absolutely no issues. Let us not.
Once it is out, we can discuss. We can.
Initially also somebody was making a statement regarding sub judice, etc. Absolutely not. A judgment has been delivered by a competent court of judicature, that is a judicial first-class magistrate, and we are just analyzing it. And I dare to make this statement in the presence of Justice Ramakrishnan sir also because in our platform we discuss threadbare the decisions of the apex court, not just a magistrate court, and all other courts wherein when we are indulging in academic discussions, there is absolutely no way anything could prevent us from discussing that, but it should remain academic. That's all. And emotions should not take what do you call precedence. So what I wanted to convey in the whole evening, I was waiting for that 5 minutes gap, is only this. That is, we live in a country where there is rule of law, where rule or law governs and not individuals. It is equally applicable to Tom, Dick and Harry. Advocate, doctor, architect, nobody is beyond that. The provisions under which you are charged or I am charged or anyone, anybody for that matter in the country is charged are the same provisions. And for that matter, if you have any difference of opinion or a quarrel regarding the law of the country, the best person to complain is look at the mirror. Because the legal system or the system in any civilized country works on a principle wherein the legislature legislates, the executive executes, and the judiciary interprets. The court does not make this. Judicial first class magistrate did not create a law one fine morning and condemn a doctor. Absolutely not. When it hurts, we feel that, okay, we are being condemned as a lot. Lawyers are also being condemned. Architects are there. Other businessmen are being condemned. It's happening. Let us move away from the emotional plane and analyze what exactly happened in this scenario with the facts that has been provided, because Dr. Subhash only called me up late